Sciatica is simply defined as back-related lower limb pain. What are the risk factors for sciatica? We have pregnancy, certain occupations that require heavy repetitive lifting. Anatomically, each lumbar disc consists of two components, an internal semi-fluid mass, the nucleus pulposus, and a laminar fibrous container, the annulus fibrosus. Biomechanics of the intervertebral disc. Contrary to the popular belief, the intervertebral disc is relatively resistant to failure under compressive loads. The vertebral end plate usually fails first in both normal and regenerative discs. However, in torsion, the disc is the part that fails first. The load on the spine has been shown to vary considerably with posture and external loads and is much larger than generally believed. At the L3, L4 interspace, a person sitting has a higher interdisc pressure than when standing, and the lowest pressure are obtained when the person is lying on the back, because the spine acts as a flexion boom to the high wire actions of the paraspinous muscles. It's the fulcrum of a lever system in which loading has considerable mechanical advantages. The symptoms are usually backache, which may be followed by incapacitating or relieving pain into the leg. This may be accompanied by paresthesia or numbness in the affected dermatome. It also may be followed by weakness in selected muscle groups, and occasionally the clinical picture is one of severe leg pain and cramping, which occurs very soon after the onset of symptoms. Pain is often aggravated by sitting, standing, and walking, as well as by coughing, sneezing, or straining. And in all rare occasions, severe sciatica may be suddenly relieved. However, it is usually associated with motor weakness and sensory loss because of physiological interruption of function and severely compressed nerve roots. So, the disappearance of pain is not always a good sign. And in older patients, there may be little or no antecedent back pain, and leg pain dominates the clinical picture from onset. It's not unusual to see rotative symptoms including urinary urgency, frequency including chorea, and increased post-void residual. We have the signs, which are the Lasix signs, which is called also the straight leg raising test, the cramp test, the crossed straight leg raising test, femoral stretch test or the reverse straight leg raising test, bowstring sign sitting extension test, Navigator's test, and later on we will show you some videos. In the neurosurgical practice, one of the most important spine emergencies are the Coda Equine syndrome, which may be due to compression from massive ruptured disc, usually midline, most commonly at L4, L5, and often superimposed on pre-existing conditions like the spinal stenosis and tether cord. The possible findings are sphincter disturbance, which include urinary retention, which is the most constant finding at some point in time during course, urinary and or fecal incontinence. In some patients with urinary retention will present with overflowing continence, and anal sphincter tone is diminished in 60 to 80%. Saddle anesthesia, the most common sensory deficit distribution is the region of the anus, lower genitals, perineum, over the buttocks, posterior superior thighs, and once total perineal anesthesia develops, patients tend to have permanent bladder paralysis. Significant motor weakness usually involves more than a single nerve root, which if untreated may progress to paraplegia, and low back pain and or sciatica. The sciatica is usually bilateral but may be unilateral or entirely absent. Bilateral absence of the Achilles reflex has been noted, and sexual dysfunction is usually not detected until a later time. Now, what are the investigations? First, we will start with a simple investigation, which is the conventional radiographs of the lumbosacral spine. Here we mean the X-rays, which are routinely obtained in the study of lumbar disc disease, but they usually offer guidance rather than specific diagnostic information. These forms may reveal some straightening of the lordotic curve of the spine, scoliosis, non-specific degenerative changes, narrowing of one or more of disc spaces. And the main reason for obtaining radiographs in patients with back pain or radiculopathy are: first, for exclusion of other conditions such as spondylolisthesis, fracture, primary and secondary tumors of bone, pyogenic and tuberculous infection, congenital malformations, ankylosing spondylitis, fibrous dysplasia, and hemangiomas of the vertebral body, and in preparation for surgery, because these forms may alert the surgeon to transitional vertebrae. Now, what is the transitional vertebrae? Actually, sometimes the L5 vertebrae will become the S1 vertebrae. Here we call it sacralization of L5, and vice versa. We have sometimes the S1 vertebrae becomes the L6 vertebrae, and here we call it lumbarization of S1. So, which if not recognized may lead to a surgeon to operate on the wrong disc, and also they reveal the presence of spina bifida or other anomalies that may affect the surgical exposure. In patients with previous operations, spine folds are the best way to appreciate the extent of earlier bone removal and to help plan the second operation. Now, next we have the MRI, and this technique has become the procedure of choice for diagnosis of spinal disorders. It's useful and accurate for diagnosis of herniated discs and spinal stenosis, and for the exclusion of other lesions such as spinal tumors. CT scan also a useful screening test for disc herniation. It should be done on late generation scanners with high contrast resolution. The test is less accurate than modern MRI for diagnosing most herniated discs. It has a number of disadvantages. It provides axial scan of the spine only, and usually only images the lower portion of the lumbar spine. It may miss an intradural tumor or even a very large central disc herniation. It is less useful in patients who have undergone prior surgery, and even with the administration of intravenous contrast material, it may not clearly differentiate scar from recurrent disc herniation. Next we have the myelography, which is an old method of diagnosing degenerative spine diseases, and because of the MRI, this test is used much less often, and in few cases myelography remains very helpful, particularly when it is combined with post-myelographic CT scan. So it is believed that myelography is most useful in evaluating patients who have ambiguous or non-diagnostic findings on MRI, for patients who are unable to undergo MRI, and for certain patients in whom very specific information is needed, which may be required in patients with lateral recess syndrome or borderline disc herniation, when a decision to operate may be based on whether filling or not filling of a nerve root is present, and it remains especially useful in cases where there is no neurological deficit, and when more than one nerve root is involved, and when apparently central disc herniation affects just one root. Next we have the electrodiagnostic evaluation, the neurophysiology. It's rare that the electrodiagnostic studies such as electromyography, nerve conduction velocity, or evoked responses measurement can significantly help the surgeon to decide whether or not a lumbar disc operation is indicated. When the radiographic appearance is normal, a positive EMG should not force a surgeon to proceed with an operation. The presence of electromyographic abnormalities does not make the diagnosis of a nerve root compression secondary to lumbar disc disease. And there are occasional instances where lumbar disc disease mimics a peripheral neuropathy, motor neuron disease, lumbar plexitis, or similar condition, and in these instances the electromyogram may be useful in the diagnosis of an entity rather than lumbar disc herniation. Also, when the radiographic studies show multiple levels of involvement, in the absence of discrete neurological abnormalities, the electromyogram could conceivably help the surgeon determine the route to be inspected. It is a subjective test actually, and there may be significant variability among the operators, and when there are clear-cut symptoms and signs in the absence of radiographic findings, an electromyogram can narrow the examiner's differential diagnosis. We have other two investigations, which are the epidural, venography, and discography. They are only to be mentioned because they are old and not used routinely anymore. Now, what are differential diagnosis of sciatica? We have chronic degenerative disc disease associated with osteoarthritis, tumor of the caudate rhina, vascular insufficiency, disease of the hip, peripheral nerve tumors, diabetic neuropathy and static neuropathy due to entrapment or injection. Electromyography may be a particularly useful tool in diagnosis of such lesions, and other spinal causes of back and leg pain like spondylolisthesis and anomalies of the lumbar nerve root causing pain secondary to compression of the nerve root in the lateral recess. Now, what about the management? First, we have the non-operative management. We have the bed rest. Encourage the patient to lie on a firm bed rest. I repeat, firm bed rest. And patient with backache only are allowed to continue the bed rest for 2 to 4 days, while the patients with sciatica encouraged to move after 7 days. So now we have the drug therapy. Drug therapy may be directed to relief of nerve root inflammation, analgesia, or muscle relaxation. The anti-inflammatory effects of salicylates and steroids are well known. In fact, steroids are so effective that may produce an artificial sense of improvement, which leads to disappointment when the steroids are discontinued in the face of fine discrimination. Salicylate may offer a better alternative, and acetaminophen is less effective because of its weaker anti-inflammatory properties and should be reversed for patients with permanent aspirin intolerance. We have other forms of non-operative therapy like gravity traction, specific exercise programs, shoe lifts for unequal leg length, and the brace may provide relief for the ambulatory patients with an acute herniated disc. A form of non-operative treatment that has gained favor among experienced clinicians is the injection of long-acting steroids into the epidural space. We have also the transcutaneous electrical nerve stimulation that has been used to relieve low back and leg pain. Now, what are the indications for surgery? Generally, 4 indications for operation are generally accepted. We have first a massive midline protrusion that causes compression of the coda equina, resulting in motor and sensory paresis and loss of sphincter control. Second, we have nerve root compression associated with significant quadrant surface weakness or foot drop, although some studies do suggest that early operation does not improve the ultimate prognosis for recovery. Third, we have sciatica with or without neurological deficit that does not improve on a period of non-operative management. And finally, we have the recurrence of incapacitating episodes of back pain and sciatica that may prevent the patient from living a reasonably normal life. So, as we have indications for surgery, we have contraindications for surgery. We have 5 important contraindications. A first episode of low back and sciatica pain without an adequate trial of conservative management. We have also intermittent low back pain associated with occasional pains of an equivocal nature extending into one or the other lower extremity, and equivocal results on myelography. We have also a prolonged history of intermittent low back pain and equivocal results on myelography. We have low back and intermittent sciatica pain with a myelogram demonstrating a lesion on the wrong or pain-free side. And finally, we have improvement of the patient. Actually, in the presence of significant motor weakness, if some slight improvement in the pain occurs, it may be justifiable to proceed with the surgery, and if pain is the primary symptoms, however, improvement is indication to cancel the surgery.